afternoon, everyone. I know it's been a long, exciting day, and can you all hear me okay? Yes. Very well. So I look forward to this panel discussion. We've got some great panelists that I have the privilege to be a moderator of. So I'm going to jump right into it. I'm going to be wearing the hat as an ER physician that still practices as a technologist and as a CMO of an insurance company and ask questions that are very related to what you all do in the telehealth and telemedicine spaces, and hopefully address some of the issues that we face in all those different sectors. So to begin with, in 2010, it was interesting, the American Telemedicine Association had recognized there was a lot of policies and procedures for certain aspects of telemedicine that were well regarded, such as telepsychiatry and teledermatology and teleradiology. At that time, they had seen that there's a great need for some protocols and guidelines and some hand-holding regarding how do we deal with primary and urgent care telemedicine. So they had compiled a team of experts and folks from all over the country to look at specifically developing the first national guidelines and asked me to chair that committee at that time. And interestingly enough, what we thought would be a 6 or 7 month project turned into a 2-year project, mainly because there were so many vested interests in how such protocols or guidelines or recommendations would occur. When we were doing that work, what we found was breaking telemedicine into kind of 3 buckets help really define how we would manage each of those areas differently. And those 3 buckets kind of fell, with variations in each of these 3, of course, but fell into virtual care software with integrations to EMR and prescribing and laboratory. The second bucket being RPM, also known as Remote Patient Monitoring. And the third being carts or mobile solutions and backpacks with devices that allow you to create an on-site clinic-like model. Can each of you talk a little bit about your experience with any or all of these different telemedicine categories per se, and the kind of technologies you use in these different areas, please? Stefano, we can start with you.
Okay. So we fall in the third category for most of the things we do. So we create, what we do is offer a combination of hardware, software, and services to allow EMS or nurses or remote practitioners that are with patients to connect to a physician, which is in a hospital usually or at home. And the problem we face is mostly an issue we faced at the very beginning. We thought we could do it through software only. So we thought that this was something that you will have like your FaceTime, and you will find a very efficient FaceTime that will actually do it and use less and less bandwidth. And what we discovered rapidly was that the problem that you have globally in the US also is a problem that you can work with we can work with low connectivity through our software, but we cannot work with no connectivity. And in emergency or urgent care situations, where you are is something you don't control. So you could be absolutely in a place where there is no connection. And so what we decided to do was to see whether we could actually, and maybe if you've seen today on the Wall Street Journal, for example, there is something on rural America saying that it's still trapped into the dial-up stage. And so what we had to do was to develop something on the hardware side that would actually bring in the connectivity by boosting signal, bringing in satellites where needed, and being able to connect back. So for us, that has been the major challenge, and how we solved by combining the hardware and the software. And on the services side, what we did was to operate with several carriers. We work mostly with Verizon as our main partner, but then also balanced by the other carriers that might be offering connectivity in one place, covering better than another carrier, as you see with your phone when you go around and you have 1 bar and somebody else has 3 bars or 4 bars. So what we figure out that you need to use the infrastructure that you have smartly and integrate infrastructure in one way. And so the problem at the end of the day is a problem of combining these 3 things.
Mike, your thoughts?
Some great context there. We experienced a similar journey at Avizia. When we started the company, we actually spun out of Cisco Systems. It's a big hardware manufacturer, and we started with a lot of these various devices and carts. Over time, as we expanded our use cases, we found a need for more software. the way that we look at the world is sort of a hardware, little s software, big S software. So, and what I mean by that is we see that kind of playing out along the spectrum of urgency. So on the lower level, when we're talking about urgent care, sore throats, runny noses, typically that patient's in the home, ideally, or they're on the road somewhere or wherever it may be, and they use little s software. They use apps. They use different, their own devices to connect with someone remotely. On the other end of the spectrum, when you're talking about acute care and you're in a hospital or a clinic or a school facility of some sort, well, it's not really practical, or in many cases even legal, for a nurse to pull out their smartphone and ask you to say to the smartphone and do some checkups on you. Nor is that usually practical for the kind of medicine that they're practicing. In those environments where you need more diagnostic devices, you need various peripherals and scopes and things, a hardware device becomes essential. It's a way to aggregate those various devices. It's a way to have battery power or dedicated wireless and things in a hospital environment, and it works very effectively. But as we've spanned that spectrum, we've seen the need for big S software. And what we mean by big S software is the industry has evolved to where it's no longer about the one or two little use cases. Most of the leading healthcare systems today see somewhere in the neighborhood of 20 to 40 different use cases that are proven for telehealth. And as that explodes within the hospital, they don't want one vendor for this and one vendor for that, et cetera, et cetera. They want to be able to manage this just like any other part of the hospital in a more efficient manner. And so we see big S software as being the enterprise play on how do I bring together patients across multiple modalities? How do I integrate with the EHR platform? How do I figure out how to do different alerts and keeping my doctors straight, which facilities they're credentialed in, which ones can they practice in, where they have licensure, et cetera. And so we see a world where that's hybridized. And the middle category is really interesting. I think RPM, remote patient monitoring, will be, it's definitely starting. One of the challenges there is finding the right payment models. But in the future, that becomes even more important because it lets us tap into all the chronic care side of things. And so that's something we think a lot about. We're not big in that space yet, but want to be. But all parts of that, I think, become essential in the healthcare delivery system for telehealth.
Great, thank you. Ron?
I'm with the United States Army. We're a small startup, but we have aggressive expansion program outlined. So it's interesting from our perspective. A lot of what Mike and Stefano have mentioned are exactly the types of lessons learned that we've gone through. We've learned that when talking about telemedicine, which we now have dubbed virtual health, everything starts with connectivity, and we reverse engineer out of that. We've also gotten a lot smarter about the need for the big S software. We've got so many siloed systems that it's really become a kind of a Tower of Babel situation at many of our medical facilities, particularly when you talk about the 10 million beneficiaries MHS has. 60% of them get their care and off network. Now, while we're exploring aggressively each of these three areas, for the 10 million beneficiaries that currently get MHS care, we've determined that many of these situations are really a proving ground for the 300,000 soldiers, sailors, airmen, and Marine that are outside the United States at any given time. And my specific lab, the Telemedicine Advanced Technology Research, TATRC lab, our focus is operational medicine. And how do we bring the lessons learned from our partners in industry to bear in areas where there's no connectivity, where your user persona is an 18-year-old medic with limited training being shot at, and might have to take care of those soldiers or those wounded casualties for 48, 72 hours. So bringing the complexities that my panel colleagues have spoken of into situations that are warfighting, of warfighting nature is a very unique aspect to the types of requirements that we're looking at. But as demonstrated through the DoD's fairly large EHR acquisition program, we have realized that the answers to many of our problems are outside the room, that we do need to reach out to industry and learn these lessons, such as how swyMed has gotten through using real-time video with limited to no connectivity, the telemedicine carts that Avizia has, these are all things that we can bring to bear in our military treatment facilities. We've just dubbed Brooke Army Medical Center our virtual hub for virtual medicine across the MedCom, and many of the solutions and many of the lessons learned that are coming from folks in this room are being tempted and tried and partnered and piloted throughout those facilities. So it's, to answer your question, we're focusing on all three, specifically remote patient monitoring, but many times we're really trying to sort out what industry and trying to sort out what the tea leaves are going to be in the other areas such that we can follow those lessons.
And I think you all illustrate a very important point about how much collaboration is really going on in making just telehealth advancements successful. On the flip side, being the medical officer of a health insurance plan, we recognize there's a lot of challenges in telemedicine, which I'm sure you're aware of. Some include, as you pointed out, Mike, reimbursement models can be much improved to encourage growth. There are also issues related to provider and patient acceptability, and frankly, just jumping on board with a new way of receiving and delivering this kind of care. And also physician licensing barriers. As we know, in many states, you have to be licensed, or if you don't know, you have to be licensed in the state in which you're providing care to that patient. So with these challenges, I'm curious to know how you are working towards overcoming these obstacles, and if there are any other obstacles I haven't mentioned, which ones have you encountered that maybe we can all learn from? Ron, we'll start with you this time.
So this is certainly something we have in common with the commercial industry is policy eats technology for lunch every day. We just, within the last month, got approval to use things like Adobe Connect for virtual care and to allow credentialing for providers to operate health across state lines when providing federal care. Telemedicine comes to a screeching halt when credentialing doesn't allow that provider to provide care anywhere further than their geographical state region. So understanding and navigating those policy waters are a big deal for us. But we have found in the Army community and you find in the vendor community, we spend a lot of time trying to figure out, can we, and not really stopping to answer the question, should we? Telehealth can very quickly become an overwhelming amount of data points and biosensor inputs that can become white noise. And from our perspective, we get pushback from the provider community saying we don't want to be responsible for all that information. I've got providers saying, I don't care about Fitbit data. Tell me when my mom hasn't opened up her fridge in 2 days. The type of data and trying to make it meaningful such that the culture of the medical community finds the value in what telemedicine can provide is critical for us. We tried to push biosensors onto our special forces community, and we ended up monitoring the vital signs of a donkey outside Jalalabad for 4 days. Very fit creatures. And I'm curious what my panel will say, but where the science meets the social, that is really the critical juxtaposition of telemedicine and then the embrace of the culture, if you will, from the medical community that says, yes, there is value there and we want it.
So I would say there are two elements to telehealth. One is tele and one is health. And there are two separate things to some extent, but they have some overlaps. I'm an economist by training, so I would bore you to that. But the thing, for me, the problem is that patient outcomes should be driving, and patient outcomes are aligned. If you go and look and do some return on investments, for example, the measure of that in terms of quality adjusted life years is something that is more of an interest for a payer. So to some extent, when you go and discuss urgent care, you will have the EMS providers who work on a reimbursement model are not necessarily willing to invest in new technology. You will have health systems that might be integrated or not integrated. They might own the ambulance company. They might be also a payer and a provider at the same time. A lot of the benefits, when you go and look at telehealth, are benefits that are part in terms of reduction of cost for the provider. A lot of those are also in terms of better outcomes for patients and translates in less costly patient for the payers. So to align those, I think is the most difficult thing, then goes back to the reimbursement models. So very often the question is, great, this works, this creates better patient outcomes. But then who pays? And who gets the ROI? And if there is no reimbursement for it, where do I get my money? And in many cases, the other aspect that we see is that it depends on how you see your health system. I mean, I say health system because once I went to one of these hospitals, as I used to call them then, and I was told that I should not refer to them as hospitals ever. You know, when I refer more to the health system situation. And the problem there is, are you looking at it in terms of your cost or in terms of the revenues that you can bring in terms of more outpatients that are coming to you, and a more intelligent way to use your resources in a digital fashion, Best Buy style, you know, the brick and click, so that you really get the patient that come to you are the one that really need your services like surgery or other things you need to do there, and patient that can stay at home and don't need to be admitted should be staying there and use your health systems only in a way that makes sense when they really need it. And the main problem at the bottom is that where is Marcus Welby? And it's one of the reasons that you have in the US. And if you look at OECD scale, the US is last of all OECD countries in terms of number of primary physicians compared, you know, per thousand population is 0.31, okay? And in average in Europe is between 1 and 2. So the problem at the end is that you get a lot of people that come to you that shouldn't be coming to you. How do you address that digitally so that you get maximum in terms of your revenue and your vision of your health system?
Great point. Mike?
There are a lot of issues in this industry. I think anyone that plays in the healthcare industry knows that that's part of the game that you sign up for, but the reward is fantastic. Other great points are made. I'll touch on a few others. One is utilization, and by the way, these are a little bit of a perverse circle of life. That without one, you sort of struggle with the other, and we struggle to break out of that challenge. So utilization is a big one, and it's not that the consumers don't want it, because I think we've proven that given the right tools, they will embrace cheaper, better, more efficient means of care wherever they can. But getting the health systems to invest in it, getting health systems to break out of the pilot mode. And, you know, I mentioned one of my clients earlier, they have 43 service lines that they have proven for telehealth, but they have 4 that they believe are at scale. It's telestroke, behavioral health, ICU, and urgent care. And it's not that the payment methods are perfect on that, but they've hit a break-even point and they can go deeper in it. But that doesn't mean they don't want to do oncology or, you know, genetics counseling or other things over telehealth. So what helps drive that? Well, cost is another one. In a strange way, it's our job to keep driving costs out of the system. Now, as innovative companies, I know one of my colleagues here runs a very innovative company. That means we need margin to drive innovation, and yet our job is to lower that cost to make it so hospitals are more likely to invest. And so we spend a lot of time figuring out what are all the different ways, and industries will evolve. You know, 20 years ago, it was all carts. Well, frankly, it was TV cameras that people were setting up and using satellites with. Today, you know, we're trying to figure out ways to make this work really, really well on your phone or your iPad or, you know, a small tablet PC or whatever it may be, so that we have, you know, pervasiveness of telehealth access. But I think the next part of that, and that my circle of hopefully of life, is just the regulatory environment. And that is a huge challenge right now. I think what drives this whole issue, if hospitals could pay for it, they move beyond pilots, and then we could do more, and then we'd lower the cost, and then we'd all have lots of telehealth. Regulatory is a big deal. And I would encourage all of you, if you want a homework assignment, go talk to your local senator or representative about the Connect for Health Act that we're trying to pass right now. One of the big things that it changes is it removes the Medicare restriction that today limits telehealth coverage to rural areas, which A, changes every year, and B, is a really small part of the country. Once that changes, we think payors will embrace those same coverages as well, and that literally will unleash, to me, the other 39 or 38 use cases that hospitals want to do. It's not that they don't want to do it, but if I get paid doing it this way and I don't doing it this way, incentives drive behavior. And I think in particular, so I was with Secretary Price 2 days ago. We had the chance to meet with him and talk about telehealth policy. For better or for worse in this town, every 2 years, there's a small window of opportunity where things get done. And it's not that it's one party though that doesn't want to get things done. It's just that the windows align to get policy done. And we're in one of those windows right now. And I'm very optimistic that we'll see some changes coming through with telehealth, which to me will help start to break that cycle and help us start to see telehealth more pervasive across the healthcare.
I think that's a great point. And when you talk about how Medicare can drive a lot of subsequent change, especially in the commercial markets downstream. Along the same lines, just an add-on question to that is, and this is for anybody, we don't need to have all three respond as you wish, but what is your experience with generational adoption with telemedicine? So, there's the claim out there that the telemedicine is basically the preferred modality for the millennial generation, and the opposite is applicant to the baby booming generation. Mike, you look prepared to answer.
Yeah, I think that's a stereotype.
Yeah.
And I guess I'm a little biased because we really started heavily on the acute side, and there aren't many millennials that have strokes, thankfully. And generally speaking, if someone shows up, so for example, I think UVA was here earlier this morning. We help UVA they have 160 telehealth clinics across the state of Virginia. So if you show up in Culpeper, Virginia having a stroke, there's a good chance you might end up on a telehealth device consulting with a board certified neurologist who will most likely save your life. That person is usually over 50 and they have no problem whatsoever using that technology. In fact, they're quite excited. I do think it's true that when you've got a sore throat, it might be a little more intuitive for millennials to use those. You'll find that I think somewhere around at least 50% or so of people actually have coverage in their plans now for telehealth. Utilization is actually really, really low. It's less than about 2% because people just don't realize it. And all it takes is to be on vacation somewhere in Hawaii and, have your kid have a funky rash breakout, true story, and you realize how fantastic this really is, that for a very small copay to see a doctor instantly and get a prescription, the convenience is amazing. On the flip side, we talked about remote patient monitoring. Again, it's driven primarily towards people with chronic conditions. I've seen case studies of 85-year-old women that are getting on their tablet every single day to do their check-in with their doctor, and it's fantastic. Cases where they have multiple chronic conditions and they're at a hospital, usually the ER, 3, 4, 5, 6 times a year, and now they're not doing it at all, and they get to a sense of some normalcy in their life. So the good news is it applies across generations. It may be that there's more of a forced uptake when you show up for a stroke or whatever it is on some of the other folks. But what's great is the satisfaction is equivalent across all of those. And people that use it love it.
Very good. Thank you. And it sounds like in summary, there may be some modalities of telemedicine in those three buckets I generally classified when we started this talk that may be more conducive to certain populations versus others. So that's a great point. So now going on to a topic of security, a hot topic across all industries, and just as sensitive and important in the healthcare industry. What measures are you taking in your various roles to ensure that as telehealth expands, and there's no question about whether it's going to expand, it's just how fast is it going to expand. I think we all agree on that. Is what precautions are you taking going forward as this expands to prevent the hackings, the protection of patient information, and protection of patient encounters through these modalities? Stefano, you want to start?
Yeah. In our case, it's we do the live encounter, so we usually have it. It's rarely scheduled. It can be scheduled, but so most of the times what we do is, in terms of integration with the EMR, everything is left within the EMR itself. So we have a secure transaction over that. The second aspect is that we have a private network, even over mobility. So we don't travel on the public internet. So all of that is encrypted. On top of that, we encrypt the video and audio that we send and the data that we transfer with AES 256-bit encryption. So it's all protected. And the last part, we do not store. And even though there is the possibility of storing in some cases, which is you can record one of those, it's very rarely happens. And if it happens, again, it's stored where the EMR is. So as far as we're concerned, what is really crucial for us is to keep all the information encrypted and confidential across.
Hey, Ron?
So security is almost a sore subject for our area in telehealth. The DoD has a near draconian approach to cybersecurity, particularly when it comes to healthcare, particularly when it comes to our soldiers. We have a not invented here mentality when it comes to any of our software solutions. We have to own all the servers. We have to have hands on everything. No, you cannot access it, even though you're the vendor. We're letting go of some of these outdated modalities now that we're working with partners such as our EHR device, but particularly for our downrange operations, it's a tough situation. It's a well-known fact that medical devices are the least secure devices you'll find on the market. Trying to find ways, Big Army will not let us put any of our medical devices on the networks. Trying to find ways, whether that we have aggregators or sniffers that can receive some of this medical data and transfer it secondarily, that might be an approach, but it's certainly something that we are looking to our partners and looking, growing, if you will. There's some things we do very well, but when it comes to being open-minded about certain things, perhaps not one of our strengths. For good reason, I understand. But the area of security is certainly something that we've taken a very hard stand on to our detriment when it comes to telehealth projects. And it will really take the lessons learned and the value from the other sectors to show us that we need to shift some of our policy and that we need to introduce some more approaches to allowing other folks and third-party vendors in to be partners with us when it comes to things like security, when it comes to things like our medical networks.
Thank you. Mike?
I'll talk briefly on it because great points have already been made. There is a tricky balance, right? Perfect security at 99.9999, right? May be possible, but the cost and the limitations it places on access are not really feasible. And yet I'll tell you, I'm sure you have a similar feeling. I wake up just a little bit terrified every day. Anytime you hear that, we've had many systems here locally that have been compromised by ransomware, the WannaCry virus a couple weeks ago. And the first thing that we all do is we call our tech team, just making sure we're good, right? Okay, good to hear. We do store patient health information. So it means we work in a very close partnership with our various healthcare providers. It means that everything's behind multiple VPNs of access, that every single, we have very strict user policies, everything down to we have to have locked doors in our buildings, and we have to do sign-in logs, and we have to do regular password changes. Every summer, at the very least, and sometimes twice a year, we do a series of pen tests where we pay outside contractors to try and get in and help us audit our security policies. So there's a lot of things that can be done, and we do all those things to do our very best to get to what I'll call four nines, 99.99. Somewhere in that range, I think is where we need to be and where we need to strive to be and do everything we can. And yet at the same time, we embrace things like the cloud. It's not possible to impact things like the cost without embracing some of those technologies. But I'll give you the downside. When Google's DNS went down about a month and a half ago, it took our systems down for 5 hours, where they were up and running. You just couldn't find them if you didn't know the IP address. And we did workarounds for our customers, but there will always be some of those risks. And yet, candidly, innovation to a certain level is balancing that risk to make sure that the access is there in a reasonable way, right? 256 encryption is a no-brainer. Making sure that we have the right policies are no-brainers. But it isn't feasible to have a dedicated line point to point between every two people that want to connect. So it's a balance.
And I think that's a great point. I was at a healthcare security conference just last week, and one of the things that came up that I think was really critical to understand is now more and more integrations are taking place. Not one vendor is carrying all the cloud and carrying the telemedicine solution and then connecting with the EMR. It's not a single vendor solution in healthcare or most industries now. And the more time you patch together pieces of a service delivery like telemedicine, the more you are apt to get a breach. It's just frankly the way it goes. Maybe a question for just one or two of you to answer is, what are you doing to hold your partners accountable? I'm sure you're partnering and third-partying. There's a piece of a function that you're performing. How do you hold your partners accountable to make sure that you're delivering on your promise to your customer?
All right, I'll take that. To your point, what's interesting is even within the same healthcare system, we have hospital systems that we've done integrations for 4, 5, 6 EHRs at the same health system. That actually happens to be one here locally. And it's a challenge. And then you add onto that PACS integration. You add onto that, single sign-on, all these different data integrations that we do. For us, most of the time, that partner is the health system itself. And I think that's what's helpful is almost every health system I've worked with, and we get to see their various security guidelines from all of them, and they're not all the same, but they do go quite deep there, and they hold us accountable, and through BAA arrangements. I mean, we have to go get a BAA with Amazon. We have to get a BAA with every single health system that we work with, and with any vendor that we use as part of our system. But the challenge there is we have to work together as partners, and I think that's how we go at it. We do regular tests to make sure that it works. We have to share data because otherwise you don't find out if something funky is going on or not. And we do our best to make sure that we can protect it wherever we can.
And to add one thing to that, I think the aspect of certification will be important at a certain point, like you've done with a lot of the EMRs. Some of the newer solutions don't have the same level. It would be nice to have something where you go through a regular check and you can produce that, which will reduce also the time you go through security clearance and all the other things, but also provide security clearance is a series of questions. And, it's all based on the trust that you're answering truthfully to the question. And I think it's a fair assumption. But I think also the fact of doing certification and audits and checks and be able to report on that, that's also another important aspect, which has been asked by several systems nowadays. I mean, it's not everybody the same, but they ask, are you high trust certified? Have you done all of this and the other? And so I think you will see more and more of that, which is an independent agency verifying, and then the system actually taking that and verifying that that's kept. Do you have the audit regularly, and so on and so forth.
And I think this is a very important part of our discussion because it's a multi-billion-dollar cost to the health system, these breaches. And I didn't recognize that until recently when I had a subject matter expert speak on this. And when we talk about telemedicine, we're opening up a door that needs to be proactively watched. Ron, you want to add something?
I do want to say from an Army Medcom perspective, our answer to the solution, which is not viable or sustainable, is trying to own every piece of it ourselves. Our DIACAP, our Certificate of Networthiness, our RMF, Risk Management Framework processes take 2 years. It is not a viable process, and I'm certainly not the one to drive policy on that, but we hope you guys show us a better path.
Wonderful. And you lead me very well to my next question, which is some of you represent groups catering towards the private sector and others towards the public sector. So in terms of, can you talk a little bit about, and some both, can you talk a little bit about your primary consumer of services so our audience can understand a little bit about the differences in trying to maybe sell, and maybe the same, but sell the telemedicine initiative to your buyers and your consumers? Ron, why don't you start?
Sure. So obviously I work for the Army and the military. So we're a little bit different. I'm a research lab, not an acquisition area like the Defense Health Agency. Congress has challenged us with developing telehealth solutions beyond the event horizon. Where are we going to be in 10 years? So Big Army has said that our 25-year medical doctrine of being able to evacuate casualties within the 1 golden hour will not be there in 5-10 years. You look across the Eastern Corridor, what we expect in 5-10 years is we will enter into situations where for the first time in 2 generations, we may not have air superiority. Our medics will have to deal with what we call prolonged field care, where they alone will have to take care of soldiers to stabilize and help them survive for periods of up to 72 hours. Our challenge is to fill that capability gap with virtual health medicine. Trying to read the tea leaves and understand where those functional and technical gaps are going to be such that we can provide those solutions within the 5-10 year framework that Congress has challenged us requires a very unique vision, a very unique approach, and very unique partners. Within the Telemedicine Advanced Technology Research Center, we have 100 people, 95 of them are contractors. Over 80% of our solutions are co-ops with academia and vendors and the commercial sector. We are aware that innovation is not a treadmill that we can keep up with. For those folks that are interested in being futurists, those are the types of partners we specifically are looking for. And what we do is we reach out and we work with you to go after grant requests collectively such that we can move that dial forward and hopefully lay out a technical roadmap such that we can meet the demands that Big Army is putting on us to answer the prolonged field care challenge that will be laid out for our medics in the next 5-10 years. So we have a unique mission, but we say passion is the genesis of genius, and we have a very passionate group. And if you fit that demographic, we are the people that you want to talk to.
Stefano?
Well, we sell globally, so it depends, to answer your question. The way we work internationally is through integrators. So they usually work also with the public sector. We tend not to work directly. Even in the US, we go through companies that do the integration to work with the public sector. We don't, we prefer to focus on selling to the private sector in general. We work with health systems most of the time. We prefer to work with integrated health system as much as we can on specific use cases. So we do like mobile telestroke, for example, in the integration of what is done more in the systems. We do community paramedicine. We focus on remote triage in Texas and other places. So the reality is that we work there with a lot of not-for-profit, which is the other addition. And one of the things that we notice is generally when you work with not-for-profit in healthcare, it's a very intellectual sector in many ways. Evidence-based, you need to be able to prove. The time is not a factor very often, so it's a matter of proving it and going through the process. So we find that in terms of our experiences, selling to the private sector in the US, it's selling mostly to not-for-profit health systems.
We tend to focus much more on the commercial systems. This is NVTC. I'm an entrepreneur. We want to grow fast, and you can either take the route of going after large government contracts where you put your head down for 2.5 years with the hope that you get that deal, or you go to a broad customer base. I think the differences are primarily in the commercial sector. Innovation, the pace of innovation is much more rapid and much more broad because you have a universe of 6,000 hospitals you're trying to make happy. On the flip side, if you go hard after some of things like the military contracts, it's a very, very long list of specific things, and if you get them, it's a $50 million payday of some sort, and if you don't, you lost to the other guy. What I'm excited about is that we're seeing a change in some of those contracting processes. I think the Cerner announcement was a fantastic thing that sort of signified both a willingness to look at things like cloud technologies and a willingness to look at commercially off-the-shelf type systems, which I think ultimately drives better innovation. As opposed to specificity, which doesn't necessarily drive innovation. But that's kind of been our focus. And it's not to say that one way is right or the other, but as companies, we go where we can be viable so that we can keep impacting change in the marketplace.
Great, thank you. So we're in a room with a bunch of technology enthusiasts. So this question probably comes up in many conversations with the interest area like this. So where do you see the industry, the telemedicine industry, in the next, I originally wrote down 10 years, but actually the way things are moving so fast in technology, I would change it to 5 years. Where do you see, Stefano, where do you see the telehealth industry, telemedicine being envisioning in the next 5 years, people doing, providers engaging, et cetera?
I can talk about what we do because that's where we focus. I mean, telehealth is a fruit salad. I mean, there is a lot of stuff in it. So going back to your categories in terms of these mobile clinics, etc., I would say that, and also in terms of our research, one aspect that is very interesting for us is how do you link the interaction in the visits with knowledge management and artificial intelligence on the other side. So how much do you capture what is done and then make it available to, right now we're consulting with an expert on the other side. In many cases, what you do, if you're writing a medical report, very often you might be forgetting something, you might be forgetting something from a patient outcome perspective in terms of things you need to do, in terms of, the reimbursement aspects and other stuff. There is a lot of things that you can do giving back to the provider in terms of not just only consulting with an expert, but also providing back information in terms of possible outcomes, things that you can do, documenting what you're doing. For example, some of the military applications. I mean, what is happening in the field, how much of that information then is captured and provided back. And so a lot of that requires intelligence, requires the ability to capture from what you do, capture the images and understanding the images. So a lot of the things we bring through the audio and video needs to be analyzed. Right now, it's provided to a person only. I think there will be more of that will be provided to a machine that will analyze it and provide additional feedback. So for me, is the integration of this and the ability to do it anywhere, which is also our focus. One thing we see in terms of the situation around conductivity is that 10 years from now, with 5G will improve the density, but not the density of towers. But at the same time, you will have satellite, and there are lots of projects that will provide a lot of the satellite team similar to cellular in terms of RTT, in terms of latency, that you will have available almost everywhere. SpaceX has announced these 4,000 satellites that will be sent out, and 2022, 2023, they will become available. So you will see much more going into the field, being able to feed that back to a human and also to a machine and get some information. How do you balance the two is the trick. So.
Thank you. Mike?
It's impossible to make predictions about the telehealth market. I've been in it for a long time, and there's a couple of trends that I see. Number one, AI and machine learning are a big deal, and we're using those actively today. I think increasingly that will help drive efficiencies in identifying trends and having decision support systems to help make it even easier for folks to do diagnoses. I think that I'd like to just see pervasiveness and the move towards care teams. And as I talked about the pervasiveness of having all the specialties, my challenge to anyone that's at a hospital today, if you really are only doing telehealth in an urgent care platform, you're not really doing telehealth, right? That's like, okay, you do Band-Aids. Is that healthcare? Not really. I mean, we want to see it across all aspects. And unfortunately, that's a little bit aligned to the whole fee-for-service world versus a more value-based world. And I think that where telehealth can help with that is increasingly it's about care teams coming together. It's not just about the point-to-point, where there's a code, and I know if I do a stroke consult, I can get a neurologist. It's more and more about managing that health. And finally, I'll say the thing I'm most excited about is I really do think remote patient monitoring will come into its prime over the next 5 years. And it's getting beyond the traditional Bluetooth, weight scale and pulse ox and glucometer or whatever it is, and to more of the passive sensors that I can replace every 5 days, and they track if I've fallen, they've tracked my EKG, they track my heart rate. If we can get them to track blood pressure, I think we'll have, that if Apple wants to make the Apple Watch succeed, if we could just get blood pressure on that thing, it would just blow up. But I think that's going to be a huge thing because the applicability of being able to monitor patients in real time will really crack telehealth open in a massive way to impact change.
Thank you so much, Ron.
Sure. So someone had joked to me, it said, if you want to know where virtual health's going to be in the military in 10 years, look at where the civilian sector is now at a 7-year acquisition and a 3-year deployment. But I think Mike hit the nail on the head. I think those areas of telehealth that have shown return on investment, whether they be your behavioral health, your teledermatology, and your teleradiology, are going to be the proving ground that drives the rest of telehealth. And I will see, as they show additional value and as our markets show value where, hey, I don't actually have to, the biggest response we get at MTF's military treatment facilities isn't about the care they get, it's about the parking. And it's a true statement. And those types of value drivers will really push the needle. And from our perspective, at least, again, a proving ground for what we can do for operational warfighters, remote patient monitoring is really where it's at. These disposable sensors, I should say, this time last week I was on Mount Everest, and they were tracking my vital signs. My heart rate was going off the chart, but with a delay of less than 1 second. And if we can do those things from Mount Everest last week, what can we do in combat theater in 5 years is really going to be amazing.
Great, thank you. So in conclusion, thank you all for your wonderful expertise on the subject. It's always very helpful to have a dynamic discussion about this and try to cover everything in an ambitious 45 minutes. As a practicing ER physician now for more than 20 years and understanding, the shortages in physicians that I don't think is being talked about enough, and also understanding the growth of the population, especially the baby booming population that's going to be dealing with multiple comorbidities. It is a no question, no brainer to understand that telehealth is here to stay. And it'll be very exciting to see what happens in the upcoming years on how things are going to play out.
If I can add one more comment, I predict in 5 years we won't call it virtual health, it's just health.
Yeah. Yep, and I would heartily agree with you. So thank you all again for your time and energy in being here today, and thank you all for listening.